our wonderful fertility show. Excited to be here. Election night in the United States. I am absolutely not going to talk about politics because I know nothing about them, but we are super excited to have you guys with us, and we look forward to a great show. Very interesting review of all of the different adjunct treatments that have been studied in the Cochrane Library. So I'm going to go through all the detail of that with you guys tonight. And at the end of all this, hopefully we'll have a better understanding of some of the things that may work or may not work when you're doing a frozen embryo transfer. As always, we will answer your questions, which is my favorite part of the show because you guys get to challenge me, and I do my best to come up with rational answers based on the science and the knowledge of all the things fertility. Most important thing is we've had an overwhelming number of questions for tonight, so I will do my best. That's either a really good sign that no one cares about the US election or that we're really growing rapidly with our show. So we will do our best to make it all work. I think someone very near and dear to us all here at VRC is watching. So for that specific individual who is trapped somewhere she does not currently want to be, our heart goes out to you. I'm there with you the whole time, and I have some very good news for you that I have not had a chance to text you. So I will text you as soon as I get a chance, but we have someone in your corner, and I think we're going to be getting the answer and the result we want very soon. You realize you just walked right in front of the camera. Right?
No, I didn't. I didn't know that at all.
Minor technical glitch. Anyway, so we are very, very excited to have you all here.
You're good.
Lost the show. Yeah.
No, you're good.
And we'll let everybody log on, and we'll go from there. Hopefully you guys are having a good night and having a good week. It was insanely cold. I actually drove back from Toronto on Sunday after doing 2 egg retrievals, only to find that I managed to go through not 1, but 3 snowstorms on the way back to Windsor. So thank God for a reasonable car with snow tires because it kept me alive and safe. So I've been some interesting weather times. Oh yeah, don't you remember that? It's a great car, man. So we're going to start chatting tonight about the topic at hand, which is what sort of adjunct treatments or major treatments work best for doing frozen embryo transfers. So this was actually a 108-page, I don't even have 108, I have 30 of the 108 because a lot of it was just references, page document from the Cochrane Library. So just before I get into it and while people are still signing on, I'm going to chat briefly with you guys about what the Cochrane Library is. So the Cochrane Library was established for evidence-based medicine, where they take all of the little studies and they pile them into this one big review, and they get a bunch of experts who come in and they all say what their opinion is after reviewing all of the evidence and come up with these summary sort of answers where they can say, hey, you've got a reasonable response, or you don't have a reasonable response, or whatever the case is. So it's very useful because they can take very large topics like what medicine to use for a frozen embryo transfer and then break it down into all the component parts. And these guys literally get paid to spend a year just coming up with the response to this. So this was brand new. And I turned to this for 2 reasons. One, obviously, we get tons of questions about what to do for frozen embryo transfers. And 2, there were literally no new studies in any of the main journals that I scanned that I thought you guys would be interested in, because we actually stay ahead of the publications with you guys. You frequently on this show get access to stuff that hasn't even been published yet. So I needed to find something interesting, and this had just come out. So hopefully, we will be able to give you some advice on what the right thing to do is. So essentially, these guys scanned literally thousands and thousands of articles to come up with the data for this. And if I remember correctly, they went over something like 3,000 or 4,000 different articles that they went through. And once they got through the 4,000 articles, they came up with the number of studies that they actually had to use. I'll try and find it for you. The things that they were looking for were if the cycle was programmed versus stimulated cycle, programmed versus a natural cycle, transdermal estrogen versus the oral estrogens, the day that they started the progesterone, whether you should use a Gnrh agonist like Lupron versus control, differences between the agonist versus antagonist, aspirin, and then steroids. So a bunch of hot topics that we look at. And they wanted to make sure people had live birth as the main factor there. And that's what the main outcome was, but they checked for all the other ones as well. And so basically they went through thousands of articles. They ended up coming up with 1,417 that seemed appropriate. They ended up at the end of all that with 30 studies that actually met the full criteria. So again, they're whittling away a lot of the trash, a lot of the articles that don't fit, because they didn't meet the criteria one way or another. And they are very strict about the criteria. So it's pretty important to make sure that you are knowing what studies are included. The thing with a meta-analysis like this is we always say garbage in, garbage out. So if you're putting in bad data, you're going to get out bad data. Okay, so the first thing they looked at was a stimulated cycle compared to a programmed cycle for women undergoing embryo transfer with frozen embryos or embryos derived from donor eggs. And the reality with this one was that the live birth rate for a stimulated cycle compared to a programmed cycle was absolutely no different. So whether you took letrozole or you took birth control pill, it did not make any difference. They actually got the same result. Now, I know for sure we've reviewed a study on the show, which was not included here, that actually did demonstrate a benefit. And since then, I've seen several others that also have shown a benefit to using letrozole. So we do use letrozole in our stimulation protocol because we think it does help. When they actually looked at the clinical pregnancy rate, it was statistically significant in favor of the patients using letrozole. So live birth rate was not, but seeing a positive fetal heartbeat was. So that was good. They did not see a difference in miscarriage rates or any of the other outcomes that they were looking at. They did look at the endometrial thickness, and they did notice that there was a slight difference in the endometrial thickness, but it was not clinically significant. It was 0.05 millimeters difference. So not something we would get too excited about in terms of the thickness of the endometrium. So does stimulated versus program make a difference? It would appear that doing a stimulated cycle may be better, in particular with all of the data coming out about letrozole. Again, we support it and we believe in its use. So then they compared natural cycle to a programmed cycle. So that's natural versus just using birth control pill for programming. And they did not see any difference in live birth rate, in clinical pregnancy rate, or in miscarriage rates. All of those were statistically equivalent. There was no differences between any of them. But they did see a much higher, 40% higher rate of cycle cancellation in the people that got the birth control pill cycle versus the natural cycles. So there are some people who will not necessarily respond well when they're doing a frozen embryo transfer and they've previously been on the birth control pill. We do use it from time to time, and yet we haven't really seen that highest cycle cancellation rate. But obviously in this particular study, and it was totaling about a total of close to 600 patients, they were seeing a bit of a difference in terms of the success rate of getting to the actual embryo transfer. Some people had to be canceled. Undoubtedly, they'd be canceled because of the fact that their lining was not developing or there was a cyst or whatever the case was. So this was significant, and it was quite highly significant. Again, it's about a 40% increase in the cycle cancellation rate. So that's really, really important to keep in mind. Okay, what about transdermal estrogens? Well, with the transdermal estrogens, versus the oral estrogens, they said that there was actually no difference whatsoever in any of the groups. So they looked at live birth rate. They didn't actually have any responses. They looked at clinical pregnancy rate. They said that there was no difference. It was statistically equivalent. And they looked at the miscarriage rate, and they said that that was actually the same as well. There is a very, very recent study, it was just out last week, which actually said that the transdermal estrogens had a similar profile in terms of efficacy, but the patients preferred it to taking the oral estrogen. So there's no difference in terms of the outcomes, but it's a reasonable thing to consider in terms of the convenience of taking it. Okay, the most important one, because people ask about this all the time, especially with the ERA test and what some people think is so important about the ERA test. And yet again, there was another study just published which showed that it does not help. So the final nail in the coffin of the ERA test is long gone and done. It is a useless test. So starting administration of the progesterone earlier, which was the day before they did the egg retrieval, versus starting it later, which was the day of the egg retrieval or the next day. And that was quite highly significant. So there is an 87% increase in your clinical pregnancy rate if you started your progesterone later and not earlier. And that makes total sense because starting at the day before your egg retrieval is birth control. I mean, that's way too early. You will have endometrial asynchrony. So you definitely do not want to start your progesterone too early. You want to start it just on time. And that's really, really important. So this is kind of a critical finding in this particular study. And that's, really important to remember as far as the duration. Now, people ask all the time, what about 120 hours, 124 hours, 130 hours, 44 hours? So the data, as far as we know, shows that if it's a day 5 embryo, you can transfer it after 5 days of progesterone or 6 days of progesterone. If you're doing a day 6 embryo, it should probably be transferred after 6 days of progesterone. The success rate is not different, but your miscarriage rate is lower. And we've actually shown you that on this show before. You can find it on our YouTube channel, www.youtube.com/Dr. Victory. So we have a whole show dedicated to that study. Okay, what about GnRH agonists compared to control? So this would be using Lupron versus no Lupron. It actually is significant for live birth rate, 162% increase. So when you use the GnRH agonist, they actually improve live birth rate. My argument for that would be that you are normalizing everything so that it's just what you're doing to the patient, which is probably beneficial. And on top of that, if the patient has endo, there may be a benefit for those who have endometriosis and you're reducing the endo. So these are really important findings. Interestingly, they did not see a difference with clinical pregnancy rate, miscarriage rate, or any of the other findings, but the live birth rate was very, very significant in that study. Okay, what about differences between GnRH agonists? Basically, there was no difference, so that was not a really important thing, and I don't think that that would make any sense either. The really interesting thing is they did compare doing a GnRH antagonist to agonists to show what the difference was. And what they demonstrated here was that if you used an antagonist, which is the one like Cetrotide or Orgalutran that many of you have used during your IVF cycle, if you use that to prevent the ovulation, that actually was superior to using the Lupron. Now, this is not something we've done before, but it may be something we want to start doing soon because we can put people on that. The downside, it's a daily injection. The upside, it may actually work really well in terms of the success rates because it was about a 38% increase when you use the antagonist versus the agonist. I have to freely admit this is not something we've done before, so we might start exploring this. Again, there was no significant difference in any of the other categories like miscarriage rate, multiple pregnancy rate, cycle cancellation, any of those. They did look at aspirin. We've done shows on aspirin too, again on our YouTube channel. You can find them there. So they evaluated the chance with using aspirin versus not using aspirin. And in the group that used the aspirin, it was a 500% increase in live birth. So I've supported the use of aspirin before. We've been using aspirin for just about ever. I think it's a no-brainer. You want to use aspirin. So you should be using aspirin. It reduces preterm labor. It probably reduces preeclampsia. I think the success rates are definitely higher, and there's more and more data coming out for that. Finally, and I've tried to keep this show a little bit shorter for this part tonight because we have so many questions to get to. They did compare steroids versus no steroids for these frozen embryos or patients using donor eggs. And actually, there is no statistically significant impact to using steroids. The problem with the steroid part of things is that there are patients that benefit from it. And those are the ones that have either immunological issues, overactive immune systems, sometimes if it's thyroid antibodies. And so I think you need to be selective about who you're using them for. Richard Scott, who's a very famous fertility specialist, told me once that years and years ago, he had actually studied this in his own patient population. And when they did so, they demonstrated that there was a significant benefit. And so he never actually changed what he was doing. So it's not so much a fact or fiction that, for individual topic, but rather that there are elements of a frozen embryo transfer that are important for you to consider. It looks like using an agonist or antagonist is better than just doing a natural cycle. It looks like programming the cycle can have some impact for you, so that has to be carefully considered. And there is no question that it looks like aspirin may be beneficial. So all of these things are things you need to look at as you're going through your own cycle. Letrozole does seem to be beneficial, so that may be something that we can continue to explore with the patients we're using it on, and hopefully they'll get lots of benefit out of that. So as always, these shows go up on our YouTube channel. They'll be on Instagram for 24 hours and Facebook as well. And if you have any questions or concerns about it, don't hesitate to reach out to us. It is available through the Cochrane Library, so if you have access, don't hesitate to go check that out. And we will be back with hopefully another exciting topic next week on that. For now, we're going to go to questions, and I'll just take a few of the ones we have here on Facebook and YouTube, and then we can jump into the long list of Instagram questions. So I am 32. My husband doesn't have any male factors, and his DNA frag was excellent. That's great. Diagnosis is unexplained. I had 5 failed IUIs and 4 failed FET. Wow. Not PG tested. Sonic histogram showed no issues. FET protocol, S-trace, 12 milligrams per day. Baby aspirin, progesterone fragment. Prednisolone, intralipids, HCG wash, embryo glue. Wow. What protocol change and test do you recommend I do before my next transfer? I'm feeling so defeated with no more frozen embryos. Wow. Well, I think it's ASTA, so I'm sorry you're going through that. I think you've probably done a lot of the things you should. That all sounds really good. I think the question would be what day your embryo was frozen on and how much progesterone they're giving you. I think that it looks like you're only using vaginal progesterone, and you should definitely be using injectable and vaginal progesterone. I do believe that's important. You should probably have your lining checked for infection. We frequently on the show talk about Fertilysys, www.fertilysys.com. They have a test called the Hidden C. You want to rule out any infections, and then make sure that everything else about you is okay. So you got to check your weight. You got to make sure you're not smoking. Your partner wasn't smoking when you made the embryos. Make sure your vitamin levels are all good, especially your vitamin D. Get your thyroid checked. You want to have that analyzed as well. Embryo glue actually does not work, so don't waste your money on that. HCG wash does. So all of those are things that you should consider when you're going through your fertility cycle. And don't lose hope. There's always opportunity. Remember on a previous show, we demonstrated for you guys that if you have 3 genetically normal embryos, 95.2% of you will have a live birth, not just a pregnancy, but an actual live birth. So all you need is that magic number, 3 live embryo or 3 genetically normal embryos, and you're going to have a baby out of that. So without any of the other stuff, no progesterones, no intralipids, nothing, no ERA testing, all of the basics, just simple, and you'll still get a baby out of it. So don't lose hope. There's always hope. It's just a matter of finding the right embryos. And, you know, in your case, after all that, all those tests and 4 failed FETs, I would take the step of making sure that you've had your lining checked. There are no infections. They're doing all of the right things. Definitely add the progesterone and oil. Do you have any idea when partners will be allowed to be present for transfers? Yes, when public health tells us that we can have people in there, we will probably allow it. They're not doing it at Create. We're just allowing the moms in, but we do generally now, or slowly, have started letting partners in for the transfers. So that should be okay. Good evening. What percentage of embryos created with 24-year-old eggs, IVF due to tubal ligation, would be euploid? 50% of patients in that age group will have 100% euploid embryos. Overall, 25% of the embryos, 25% would be abnormal. How soon after a C-section would you do another FET? Minimum 6 months. And is there a maximum number of C-sections you would like to see your patients having? Never more than 4. Ideally, never more than 4. Okay, you want to take some Instagram shots?
Absolutely.
There's a million of them, right? So if we don't get to your questions tonight, I want you guys to write us and we will take the time to answer them. I have some time this weekend. So maybe we'll redo a quick live for the people that didn't have their questions answered.
All right. First question.
Does deep infiltrating pelvic endometriosis need to be removed before IVF?
I saw it. So the question is, you probably have to shout a little or speak louder.
Okay.
So does deep infiltrating endometriosis need to be removed? So deep infiltrating endometriosis can often involve aggressive surgery, including bowel resection, bladder resections, things like that. Ideally, it would be removed or suppressed. So I probably would favor in those cases, just because the risk of the surgery is high, doing suppressive therapy. So that would be Lupron and Letrozole for 3 months minimum, up to 6 months maximum. And that would pretty much normalize your chances. So that's the right approach to that.
My friend just experienced a miscarriage and also found out she has fibroids. Correlation?
Yes, if you have fibroids in your uterus where they're deflecting the inside of the cavity, or they're large enough to be in the wall of the uterus, but they're pushing into the cavity, that does significantly increase your miscarriage risk. If they're in the cavity, it's 100% increase in the risk of miscarriage. That's from an Elizabeth Pritz meta-analysis in fertility and sterility. So, and she's actually done it twice. So that's definitely something to look at. And they're easy to remove if they're inside that cavity.
Is that you as a baby, Dr. Victory?
Oh, yeah. The picture from the question on my my story on Instagram is the true love of my life, my daughter. So Jenna, you should be asleep right now, but if you're not and you're watching, I love you, honey. She's going to be taking over the practice in about a decade and a half. So she was very cute as a baby, and that's her.
Endo scratching to help implantation on FET.
So endo scratch is super controversial. For as many studies that show a benefit, there are ones showing a lack of benefit. Last year, we presented a study on it, and literally the week later, another study came out showing the exact opposite result. So I use it when I can't figure out what else is going on, but the jury's out as to whether or not it actually works.
Is it safe to sleep on your belly at 18 weeks if comfortable?
Yes, it's safe to sleep on your belly. It's not safe to sleep on your back if you're past 20 weeks, but on your belly is fine.
What is the average upper limit in terms of age for egg donors, given good results on AMH scans?
Yeah, so I try and keep my egg donors between 21 to 28. We will make some exceptions. So even 30, 32 is not unreasonable. Above that, you start getting into the problem of now you're getting higher numbers of aneuploid embryos, genetically abnormal embryos. So we want to keep that to a relative low number. And as a result, you want to focus in on that 21 to 28 age group.
Is there a list of dosage recommended for supplements, CoQ10, etc.?
So NAC should be 1200 Inositol depends on which one you're taking, so talk to your pharmacist, but you can find the info online. And if you're using coenzyme Q10, most formulations require about 600. Vitamin D, a minimum of 2,000. Those are the main ones we use, plus your folic acid and your general prenatal vitamin.
PIO shots or endometrium suppositories, does it make a difference?
Need both. So as I said earlier, you need PIO shots for sure, and then use the vaginal suppositories as well. Keep in mind the PIO is going into your blood, and the vaginal is going into your uterus more so than your blood. So it has a differential impact, and we use both. We always have. Let me take a couple from here again. Hi, doctor. Any thoughts on long-term birth control over 15 years? Use in DOR. I'm 2 years off birth control and feel like only now my ovaries have woken up. Is it possible to be really suppressed from the pill, from progesterone IUD? My AMH also increased from 2.2 to 9.2, which I know is just going from very low to low. Thanks for any comments. So birth control pill should not cause any problems with DOR at all. In fact, if anything, it's suppressing your ovulation, so it shouldn't impact your ovarian function. It can take a while to come out of suppression, in particular if you're stressed. That can have a strong impact as well. So get checked out hormonally. 2.2 to 9.2 is a very significant difference, actually. So you might be an interesting case. That's not normally what we see, but we definitely don't test people while they're on the birth control pill either. So it makes a difference. I am on progesterone subs, estrase 2 milligrams, 2 pills, 1 aspirin, and prenatal a day. That's good. Can I take all of these at the same time? Yes. Also, what should the time interval be between taking the progesterone and estrase 3 times a day? Makes no difference. You don't need a time interval between those. I was able to get a referral to your clinic and just wondering how long I should expect to wait to hear from you or when I should be following up. Nick, you should hear soon. Mara's got about 50 referrals to deal with, so I'm sure you are in that pile, and I will ask her to get to it shortly. Do you do the HCG wash for a first-time embryo transfer? We don't, but I'm happy to if you want us to, because it has no downside to it, and it may be beneficial. They don't really have tests for it in first-time embryo transfer, so we usually reserve it for those who have failed. Oh, this is from the lady earlier. Hi, doctor. We are both non-smoker. Awesome. Embryos were day 6, and my weight is 53 kilograms. So if your embryos were day 6, you need 6 days of progesterone. That might make the difference. So it might be a timing issue for you. And remember, you need the progesterone in oil and the vaginal progesterone. Somebody's asking me on Instagram, am I still at Gnrh Fertility? I am not at Gnrh Fertility. I am now at Create, and I am also at IVF Canada. So you can see me at either one.
In terms of diet and health style, is there anything to 100% avoid? Certain exercises, food,
Yeah, so alcohol, smoking, and drug use you avoid 100%. Don't have more than 1 caffeinated beverage per day. And then in terms of foods, you want to avoid, not 100%, but you want to avoid excessive sugar, excessive cholesterol. Mediterranean diet has been shown to be beneficial. So fruits, vegetables, grains, seafood, that kind of thing. There's nothing you want to 100% avoid other than smoking, drinking, drug use.
Is it possible to have ultrasound cycle monitoring with a medicated cycle instead of OPK?
Yeah, absolutely. In fact, we've started going back to monitoring our patients who were doing medicated cycles, even if they were just on pills, just because we weren't convinced that the data that has shown that it doesn't make a difference was as accurate as we wanted it to be. So we've gone back to doing that. Trini is just saying she missed the question about her friend's fibroids in correlation to miscarriage. Trini, there is a correlation. If the fibroids are in the cavity of the uterus or they are deflecting the cavity of the uterus. So if that's the case, you definitely want to get your friend to be seen and have the uterus assessed if they have indentations in the cavity, those have to be removed because it's 100% increase in miscarriage risk. Fire away.
Suggestion: some medicine for reducing my breasts, please.
Medicine for reducing your breasts? Wow. I am not aware of any medication that reduces breast size. You can basically, breast tissue is mostly fatty tissue, so diet and exercise will reduce your breast size. That's pretty much the only way to do it. Someone just quickly here is saying, rather than doing Fertility, which is that endometrial bacterial and viral testing, why can I not do cultures? You cannot culture the inside of the uterus. It is highly ineffective. You have to test it with PCR to actually find the DNA or the RNA of the bacteria in the uterus.
Does transferring two embryos potentially have a detrimental effect if one is good and one is bad?
No, they've studied that, and there is no effect of frozen embryo transfers with two embryos. If one is genetically normal and the other one is not, it's fine.
Can acupuncture ever be detrimental or have a reverse effects to an IUI treatment?
So acupuncture is highly controversial in IVF studies. There's very little on IUI. The reality is that they've never shown it to be detrimental. Many people believe that it does make a difference, and you can biologically actually detect the differences: thickness in endometrium, blood flow to the ovaries and the uterus. They're all, you can actually see them change. So we are believers in it, and Dr. Jen Strong, who works with us, does it for our patients. But you're never going to see a downside. It's hard to get convincing data that it actually makes a difference, but we think it does.
If PGTA normal and NIPT everything low risk, what are the chances that NT isn't normal?
So that's a complicated question. So someone's saying if they had a PGTA normal embryo and then did NIPT, what's the chance that the nuchal translucency scan at 11 to 14 weeks is going to come back abnormal? So the nuchal translucency can be abnormal for one of two reasons. One, because of a genetic problem, and two, because of a structural problem with the baby. So the PGTA and the NIPT do not determine whether or not the baby is structurally normal. So you could still have an abnormal NT, but it would be really rare. So one example is a cyst called a cystic hygroma, which is this thing that grows on the back of the baby's neck. Another would be a heart problem with the baby, which will thicken the skin of the baby. So there are possibilities for that.
When will November transfers be, and when will we receive our information?
Shortly, you should be receiving your information. If you have not heard within the next day or two, make sure you call, leave a message with the office, and make sure the girls are reaching out to you. And reach out to myself on Instagram if you still haven't heard by Friday, for sure. And I will pass it on to the girls. If I had my first FET in early September and miscarried at 7 weeks, I have 4 embryos left. Is it realistic to follow the same protocol for my next transfer? Yes. Yep, it is, because most likely you just unfortunately suffer a miscarriage because the embryos are almost always genetically abnormal when that happens. So you did get pregnant, so don't mess with success. First rule of good medicine: if it isn't broke, don't try to fix it. If I am a CREATE patient, can you become my doctor and do my next transfer there? Ooh, not without upsetting a lot of people, but yes, it's possible. I probably would try hard not to do that. Also, if and when you open a Toronto office, high hopes you will open a Toronto office, do I need to transfer my embryos to your clinic? Yep, there's no impact on transferring embryos, Vicky, so you can transfer them without any trouble, and we can chat about that. If you get a consult to see me, I'll be happy to go through all the details of different possibilities. Hey, Dr. V. Oh, hi, Lise. We are doing our second IVF cycle with you this month. Just wondering if there's anything I should avoid doing this time around with a toddler running around. No heavy lifting, no straining after the embryo transfer, but have as much as possible healthy fun leading up to it. Anything that reduces your stress is good. Stay on your vitamins, eat healthy, don't eat all the toddler's leftovers. That would probably be it. Yeah. Tell your husband to take care of all the poopy diapers. Yeah.
Why did so many celebrities have twins through IVF? Doctors have secret ways to have twins.
No, most of those celebrities are 40 plus something women who are using donor eggs even when they're not saying that they are, and they're putting in multiple embryos all at one time because they just want it one and done because they have their careers to look after. So it's not secrets of anything. It's usually not their eggs. And then even if it is, they probably got retrieved earlier in life. And now they're just trying to get pregnant and get it done. So they're putting in multiple embryos to try and get that done.
What is your FET protocol for endometriosis patients that give the best implantation rate?
So you want to definitely have those patients on Lupron and Letrozole for 3 months prior, and then go right into your normal FET protocol. And we do put them on anti-inflammatory supplements, so coenzyme Q10, NAC, inositol, turmeric or curcumin. All of those things are really helpful.
Is there a heart rate BPM I should be staying under when exercising?
120.
120.
Yeah. I got one quick here.
Yeah.
Do you check for vitamin D and iron in your patients? I'm so shocked many doctors don't check for these. We check for that in all of our patients. We've checked for vitamin D for about 1.5 years, 2 years now. And they just published a study saying that you should be doing it in with iron. So we now check for that as well. Someone from YouTube, King Khan, hi, how are you? He's saying hi, or she's saying hi, I'm not sure. Go ahead.
Do you think endo patients are more likely to have autoimmune issues?
Do I think who is more likely?
Endo patients.
Are more likely to have autoimmune issues?
Yeah.
Yes, actually there's data that supports that. So patients with endo can have a higher risk of autoimmune issues. Here's a good one. Hi, Lexi. Apologies if this is too much. Going in for IUI next week, should my husband be ejaculating or not ejaculating prior to the procedure? Should we be having sex leading up to it or not? So every 2 days, you should be having sex, preferably with each other, and then don't for the day before the actual IUI. So just 1 day of abstinence. Yeah.
Is there any new luteal phase support drug besides progesterone?
People use HCG for luteal phase support, but otherwise it's always progesterone.
Do you think Schirad-Core's sutures or simply a ring could help implantation failure?
Could what? Say that again? A Schirad-Core suture?
Or simply a ring could help implantation failure.
A Schirad-Core suture has nothing to do with implantation. It's to sew your cervix shut to prevent the baby from coming out in this early second trimester. So that's a confusing question. I got a good one here from Pink Flamingo. Low sperm count, mild varicocele and epididymal cyst, spermatocele, no female fertility issue. Trying to conceive for 16 months, can IVF be successful? Actually, those are the dream patients for IVF. So IVF would be very, very successful. Why do GPs insist on waiting a full year before doing any fertility testing? That's a real easy one to talk about. So if you're less than 35, you should actually try for a year as long as your periods are regular. Periods are irregular, you should come in right away. If you are 35 to 39, you should do it within 6 months. And if you're over 39, you should come in within 3 months.
Do you prescribe prednisone and FET? Is there a test to see if we need steroids during transfer?
Yeah, so we do provide not prednisone, but we use methylprednisolone. And we do that prior to our embryo transfers. There are tests you can do. The Fertility website actually has a number of them. We don't do further steroid testing unless I suspect that there's a problem with your immune system, but we do believe in using steroids initially.
What should be the progesterone level 1 day before transfer?
What should be the progesterone level?
Yeah.
1 day?
1 day.
Between like 40 at a minimum to 100 at a max.
And last early question. Can anything be done to prevent getting a SCH?
Subchorionic hemorrhage? Don't jump up and down. Definitely don't smoke. Don't use drugs. Low-key exercise, nothing too crazy. So just keep it reasonable. Nothing like insane. I heard that a doctor gives patients 130 hours of progesterone instead of the standard 120 for a day 5 embryo so that it covers people that could be receptive and pre-receptive. Do you agree with this? So there is no difference between 120 and 144 in patients that have day 5 embryos, so that's fine. And they're based on those studies, it actually looks like that whole pre-receptive thing is nonsense. And the ERA test does not work. Are you guys doing the IVF process at our Windsor clinic? We are still waiting for the college to give us the final approval. It should be any day now, literally. So I'm hoping by the end of the week. We've submitted everything we needed to. How long is the wait list for funded IVF in Windsor? I think forever would be the right designation for that. It's a long wait, guys, because we only get what other centers give us. We do have a team of people working on getting us funding. So everybody say some prayers, and God willing, we'll get some funding here. Can high emotional transfer pre and post transfer prevent embryo implantation? Yes. Stress has been associated with up to a 60% reduction in your success rate. So if you're really stressed, guys, you need to definitely do something about that. Do you personally, though, ever do the ERA test on patients? Very, very rarely now. Only do ERA tests for patients that have thin endometrium, and no matter what I'm doing, it won't thicken. Age 44, have 1 natural live birth. Do you suggest PRP or stem cell? So there's no data on stem cell, and there's very good data that PRP in a 44-year-old is absolutely of no value to you whatsoever. Not in terms of rejuvenating your ovaries. We are using it in some selected patients in the lining of the uterus when we want to thicken it, but that's the only reason. When should you start the aspirin? Before your embryo transfer. Like days before. Can L-arginine improve the endometrium thickness? There are some studies that show that L-arginine can actually improve the endometrial thickness. And I just saw a study recently that said adding it into the embryo media actually makes a huge difference in the mitochondrial function of the embryos. So that might be a reasonable thing to look at. We are blazing through all your questions, guys. Can super high AMH be concerning? Super high AMH usually means you have PCOS. So in that regard, it can be concerning. And you need to, check that out. And there are some risks that go along with that. So definitely be careful. Am I still at Gnrh Fertility? I answered. And then Kashmir followed that with, you used to be our doctor, but we just started coming back again and we did our first IUI. I would be happy to continue with you. I do have clinics in Toronto, but I am not at Gnrh anymore. We no longer work with one another. Love all my friends there. We just don't work together anymore. I think I missed my question. Oh yeah, we answered that one. How much exercise is too much? No heavy lifting, no straining, 15, 20 pounds max. Keep your heart rate under 120. Hello, hi. Day 5 blastocyst, weight 175 pounds, depends on how tall you are, and 2 failed FET. Could my weight be correlating to my implantation failure? And that's from MZ Gulati. Way too hard to answer that without knowing a lot more about you. I need to know your height. I need to know your general health. I need to know the sperm quality. I need to know what all your embryos were like. Most importantly, I need to know your age. DNA fragmentation? I can't answer that with just a simple question like that. Okay. Can we get rid of that? No. If progesterone levels in blood are over 10 NGL, nanograms per liter with vaginal applicators, should we still inject it? That's right around the level we're looking for. So yes, as long as it stays at that level. If the cause of infertility is lower sperm count, do you try to elevate the numbers before having your patient try IVF or IUI? Always. I always spend time trying to optimize everything about my patients before we do anything with them. So it's very rare that we just throw people into therapy, because even if you're doing IVF, getting better sperm is better. So you don't want to just jump into it and hope it works out. You want to go into it confident that you've done everything you possibly can to maximize the success rates. Anything less than that is great for my bank account, but terrible for you, and I'm not interested in that. So we make sure that we offer you vitamins, cold therapy for the testicles. We try, supplements for the guys, diet and exercise if their weight's a problem, or cholesterol management if that's a problem. We get rid of all the bad habits: no smoking, no drinking, no drug use. That's probably the toughest battle. So yeah, there's all sorts of things we do. Low AMH, 8.91, age 29, ovulate every month, no other issues. Sperm results are great. What would be the reason for not getting pregnant naturally? Oh, that's a good question. I need to know more, but make sure you get your tubes checked. Make sure your vitamin levels are up. Make sure you're having sex every 2 days. Aside from that, it could be something like endometriosis, could be egg quality if your AMH is low. I mean, an AMH of 8.9 at 29 is fairly low, so you got to get all that checked. Thoughts on bed rest post-transfer. So we have a fertility factor fiction on that. It makes absolutely no difference. So you can do whatever stresses you the least. You definitely don't need bed rest during your 2-week wait. Maybe take it kind of easy, but you don't have to be on bed rest. How many retrieval should one go through before giving up? Oh, that's a great question. Let's put that up. How many retrievals should you go through? Well, based on that study we reviewed 2 weeks ago, the answer is enough to get 3 genetically normal embryos. If you've transferred 3 genetically normal embryos in, that gives you a 95.2% chance. Now, that's just a number I'm throwing out there. It's not accounting for the emotional toll. It's not accounting for the financial toll. So I'm saying that strictly medically, but you have to weigh for yourself the impact of those other elements, because if it's going to take a financial toll on you and your family, then don't do it. But it's reasonable to try till you get 3 genetically normal embryos. And if you can get even more, because the finances or your insurance or whatever allows for that, some of that 5% we can still help by trying adjunct therapies. So, the new answer for me is always going to be enough to get 3 genetically normal embryos. When do you get your period after a failed transfer? Usually about 3 or 4 days after you stop your progesterone. Yeah. Does pregnancy alter uterine lining, which would require a different protocol for future FETs? No, it shouldn't, as long as you've left enough of a space and you didn't have a DNC. Do you think laparoscopy done correctly, like your method with no ablation, would still damage egg reserve? It is better to have endometriomas. Is it better to have endometriomas surgically removed if you have 3 genetically normal embryos? Endometriomas have a real negative impact on everything. So yes, as long as they take it out correctly, and I'm glad you pointed out not ablating. If they are burning your ovary, it's done. Like the thermal damage alone will kill thousands of eggs. So you have to cut the ovary open. You have to peel it kind of open, and then you have to pull the cyst out. You cannot just go in there and burn it. And then after you pull the cyst out, if there's bleeding, you can't just go barbecuing the ovary. That doesn't work, which you see so many times. So you got to be very, very careful. But I would recommend removal of endometriomas before doing an embryo transfer for sure. Can you please explain a little bit about the process of doing the fertility test? Can I do a consult with you just to review those results? You're welcome to do a consult with me for any results. Fertility is really simple. You basically collect your menstruation. So they send you a tube, you collect your menstrual blood, literally like scoop it up from the vagina, put it in the tube, send it to them, and they analyze it for whatever bacteria you pay them for and viruses. Once you get the result back, you can go to your doctor or me or anybody you want, show them the results, say I need antibiotics for this, take probably double or triple the normal amount of time that you would for any kind of infection, because it takes a long time to get rid of something from the uterus, and then get retested before you give up on that. Is metformin and prenatal good for PCOS? Yes, metformin and a prenatal is good for PCOS. So is NAC, so is coenzyme Q10, so is inositol. And diet and exercise, you need all of those. So remember, PCOS requires a three-pronged approach. Medication, so metformin, letrozole, supplements, coenzyme Q10, NAC, and inositol, vitamin D, all that other good stuff. And then make sure you are doing lifestyle choices. So that's a healthy diet, less than 1,500 calories a day, and daily hardcore exercise. You got to do all of those. Okay. Is acupuncture safe during the IVF process? We talked about that. Yes. Should we stop drinking alcohol completely a month prior? No, you should stop drinking alcohol months prior, because for your husband, he's making sperm 3 months before you're actually giving the sample at IVF, and the alcohol increases sperm DNA damage. So make sure that you deal with that. Do you check for vitamin D? Oh yeah, we answered that one. Such a good answer about celebrities. P.S. I think Meghan Markle did IVF. I have no idea. I'll ask her the next time I see her, I guess. I did love Suits, and I just finished watching that show. Harvey has the best suits ever. Those are awesome. Tom Ford. Apologies. Oh yeah, we asked that one. Did I miss my answer? What is a good iron supplement pill brand, and what dose should I take? We use Ferromax a lot. I love Ferromax. It has very few side effects. It's tolerated well. Palifer is really good. Triferix is really good. You want what's called a glycosylated iron, which means it's got little bits of sugar stuck to the iron, which makes it easier on your digestive system. What else have we got? Can progesterone be taken rectally rather than vaginally? Probably, yes, although that would be messy. I would probably just use it vaginally. Is acupuncture safe during IVF? Oh yeah, we asked that twice. Is 31 old when doing IVF? No, absolutely. That's not even remotely old when doing IVF. In my opinion, you're probably, I never say the word old to anyone, but your reproductive age is starting to get more advanced when you're hitting your late 40s and early 50s. After that, it starts becoming more questionable, but I never judge. We've had older patients want to do it and get pregnant, even have twins. So it's perfectly fine to do that. And Philip's asking for his wife. After a failed FET, my doctor wants us to have a withdrawal bleed, and 2 true periods before starting another FET protocol. Why? I think there's no reason to wait at all. You can jump right into it. Should you be seeing even a faint line on a Preg test 12 days after an IUI cycle, or not anything to worry about? Not necessarily. It depends on your test, exactly when you ovulated. So we usually just wait until you've passed the actual formal time for your period to occur. If we are not able to be sexually active the week leading up to the IUI, will this have a negative effect on the procedure? Are there benefits to having sperm in the body leading up to IUI? There probably are. There's actually some studies that show that IUI and IVF work better when you've had more sex. And it's probably something about the prostaglandins and the chemicals in the ejaculate priming the system, or maybe it's the endorphins. I don't know. Hopefully you're having good enough sex that you're releasing endorphins. Either way, it would be better if you could, but it's definitely not a deal breaker if you can't. Having said that, Lexi, your partner needs to make sure that he is ejaculating every 2 days with or without you, but definitely not with anybody else. Okay. Sometimes you got to throw this stuff in there, right? Apart from PGS, is there any other testing to know if the embryos are genetically normal? So we're actually exploring right now with a company and some research whether or not we can do PGT by just sampling fluid from around the embryo and the fluid in the embryo without actually having to tear a chunk of the embryo off, which is essentially what we do when we do PGT. They actually laser off a piece of the trophectoderm, which becomes the placenta. And there's some data actually suggesting that the fluid around the embryo and the biopsy from the inside gives you an even more accurate result. So we're looking at that right now, but that is the only way to do it. There's also a lot of artificial intelligence programs going on. The latest one I saw had an 80% predictive rate. So not great, but not terrible. So it's something to consider. Can your success rate in regards to egg retrieval be lower from one transfer to the next? I think you mean from one cycle to the next. Yes, for sure, it can. At home, our tests show I ovulate day 9 to 10 of the cycle. Is this possible? Seems early. Possible, yes. Early, yes. Take letrozole. It'll solve the problem and delay it for you. Why did you say ERA does not work? ERA testing is useless. Do not do ERA testing, guys. Their own study, which we reviewed on this show, what was that, a month ago? Again, on our YouTube channel, useless. It does not work. ERA testing is a waste of money. Do not do the tests. Totally, totally useless, epically useless. Every study over and over and over again published, not a single study out there has shown a statistically significant benefit to the ERA test. It is dead. Sorry, I asked this at the very beginning, but I think it was missed. Oh, hi, Carrie, sorry. Pregnant and breastfeeding, my first still. Thoughts, stop breastfeeding. You're producing oxytocin, which makes your uterus contract. It's time for a junior or juniorette to let go of the boob. Is it dangerous to flight more than 6 hours, 4 days after an embryo transfer? Yeah, you definitely do not want to be going anywhere for that long a flight. 4 days after an embryo transfer. I would say minimum weeks. Do not jump into a plane and fly 6 hours. Air pressure changes alone would be detrimental. Last couple of questions. I'm racing through it, guys. Did 2 IUIs and several cycles of letrozole, natural cycles, PCOS, get my period only with medication? So with PCOS and low sperm count, should we try IVF now? If your sperm count is low, for sure, but it doesn't say doing IUI. You could try, oh, you did 2 IUIs. Yeah, I mean, you could try some more IUI. Depends on how low the sperm count is. Alternatively, jump into IVF. It's not unreasonable. Do you repeat a hysteroscopy when removing a polyp, products of retained conception? No, we do a saline infusion sonohystogram, so we don't actually have to torture you with surgery again. Do I work with clinics in Vancouver? Absolutely. We have lots of patients coming from Vancouver. Our clinic asks for 4 days of no ejaculating before IUI. Why do you suggest just 1 day? Because 4 days increases the amount of sperm DNA fragmentation. That's not right, so don't do that. And you can tell them to produce some data for you if they are. Wow, I just skipped a whole bunch of these. Sorry, guys. Okay, well, we're closing down. Okay, guys, if I didn't get a chance to answer you, make sure you follow up with us. It was a great show. Thank you for joining us. We love you guys. Ask your questions. A couple of you sent me long messages. I will address each of those with you as best as I can. Have a great night, and let the best man win tonight. So let's see what the American elections show. Take care, guys. Have a great night. Bye now.